Good morning, good afternoon, or good evening, wherever you guys are at. So today we're going to talk about floaters, tears, retinal detachments, a primer. I will go through some slides quicker rather than slower with others. So we'll kind of get to the main point of the topic. We're going to talk about retinal tears, floaters, wide angle imaging, repair retinal detachment timing, and some anterior segment issues. So these are some infrared photographs that show a vitreous hemorrhage with a retinal tear. I find these to be quite useful, but we're often faced in patients such as this who come in with a vitreous hemorrhage and have tears and or detachment. And so a common dilemma we face is when you see a tear, certainly it's easier, but you have a phakic patient with a spontaneous dense vitreous hemorrhage, what do we do? Visions count fingers, there's no tears that are seen on B scan. So there's an issue of early versus delayed vitrectomy for these sort of patients. We published on this, and I'm going to go through what we found. But this is really a frequent reason for referral to us and also to general ophthalmology. Ultrasound is useful as an adjunct, but it's going to miss some of these low-lying detachments. The options really include observation or early surgical intervention. And here's a patient that shows vitreous hemorrhage on the left, and here's on the right a retinal detachment that another patient had as well. So we look at these patients, and we're talking really about grade 3 and grade 4 hemorrhages that are too dense to allow visualization of the optic disc, not grades 0, 1, or 2. So what do we recommend? Do we wait? Do we do surgery? Does it matter if they're phakic, pseudophakic, blood thinners, and are there other factors to consider? Etiology is typically retinal vascular disease if it's not retinal tears, but the most common in these patients after retinal vascular disease is either tear and or detachment. If you look at the ultrasound detection for on ultrasound for both retinal tears and detachment really wasn't as great as we would think. Detachment was about 54% and tears about 20% or so. So we know that small gauge surgery has good outcomes and there's really low risk of complications. Certainly it's not zero, but there's it's a low risk compared to before. You know, I always tell our fellows and patients that if I can't see in and you can't see out, it is really hard to guess what happens in these patients in terms for what they have. So we looking at the surgical and visual outcomes for both adult patients, non-diabetic fundus vitreous hemorrhages that underwent early or delayed vitrectomy. And we looked at this over a 5-year period, and all patients underwent B-scan. If there was a high suspicion of tears or detachment, obviously surgery was performed, so we excluded those patients. We had about 275 patients, and then we whittled them down to about 52 eyes of 52 patients. Average age was 61. The timing was the discretion of clinician. Early was less than 10 days. Later was after the 10 days. They underwent standard 23 or 27. Typically, most of my cases for retina, I do 27, sometimes 25. We hardly ever do 23. But again, that doesn't really make a difference. It's the gauge doesn't make a difference for this. So here's a patient, a video who is found to have a vitreous hemorrhage. And you can see dense vitreous hemorrhage as we're removing the hemorrhage. And as we remove the hemorrhage, you can see down below, we would have never really seen this because there's blood down below. Even on ultrasound, it would have been difficult. So she had a tear up above, a pretty large break, also a tear down below. And you can see that most patients, and here's the breakdown below, get a vitreous hemorrhage for a known reason, but typically tears and or detachment. And this would have been missed and patient would not have done well. And they've actually done well with visual acuity improving to 20/20 actually. So again, this is 27 gauge surgery, and I just cauterized the incisions with the conch over it. So what do we find? Retinal tears, retinal detachments, as you can see in about 75% of these patients. And if you look at the initial and final visual acuity, the p-value was 0.67 because obviously our numbers were small. So there was no statistically significant difference in the visual outcomes, but the number of operations when we looked at with the larger group did vary between the groups. The type of tamponade used did not vary either. Now, what we did find was that the sensitivity for retinal tears was 24% and detachment 58%. So a large number of detachments and tears were missed despite having ultrasound. Of the 69 with retinal detachments, 12 were phakic, 4 were pseudophakic, and this did not achieve statistical significance. Again, the numbers were small. So our results show that there's a high rate of retinal tears and detachment in these dense vitreous hemorrhages. Although early vitrectomy did not show significant in visual outcomes, it did raise a suspicion for the treating physician that the ultrasound was only able to identify retinal break in quarter and detachment than 50%. What's interesting is phakic patients had a much more likely issue of a retinal detachment than pseudophakic eyes. And I think the odds ratio was 2.14, and this really shows to the abnormal vitreoretinal interfaces that are in these patients where the separation may be incomplete and irregular. So we think that early vitrectomy is safe and effective and certainly can be very useful in these patients. We all know that myopia is a worldwide epidemic, and we expect this condition to increase over time. So really young phakic myopes are the highest risk for retinal tears and detachment. And my conclusion would be, if they can't see out and you can't see in, just don't rely on the ultrasound. Now, what about the use of OCT in some of these patients who come in just with an acute PVD? And can that tell us something about maybe a small amount of hemorrhage that has been noted, that has been missed in a clinical sign on examination? So we know that Schaefer's sign is the presence of photoreceptors or tobacco dust. OCT has been shown to demonstrate these posterior vitreous opacities that may correlate with these signs. So we want to look at the sensitivity and specificity of these findings. So this was a retrospective chart review by us, and we did mass qualitative review of SD-OCTs by a single reviewer to identify these PVOs, and they were considered positive if 3+ opacity were seen in the vitreous. Sensitivity and specificity or presence of PVOs was then calculated. So this was looking at demographics and comparison of patients with a break or PVOs against those with and without. And you can see in this chart, and I'll go through the data. So when we looked at it, that the presence or absence of PVOs with and without all breaks, and if you look at all breaks down here in patients without a vitreous hemorrhages, the sensitivity was 76%, specificity 75%, sensitivity 82%, and specificity 86%. So in patients with symptomatic PVD, the presence of these things that we see right here, and this is easy to get, correlates with the presence of a retinal break. The absence of the opacities makes it much less likely that retinal break is present. So almost there's a 9 out of 10 chance there's a break if you see these findings on OCT. So that's really important. And if you see that without a vitreous hemorrhage, but you see these findings, then you really got to look carefully for a retinal break. So that's a very important kind of a take-home message with imaging. Now, we also often get asked about floaters and the management of floaters. It's a common thing that a lot of our patients complain about, both primarily from just a PVD and or let's say status post scleral buckling surgery. So here's a 71-year-old female who presents with floaters, recent cataract surgery, vision is worse after surgeries. And this is what she sees. She sees this big glob, and I use the infrared video on the Heidelberg. It works really well. If you have a machine like this, it's really important to use, and we can see what she's seeing. So in this patient, really, it's the quality of vision that makes a big difference. And we need to make sure that we understand the terminology. Myodysopsias are floaters, and visually degrading myodysopsias are clinically disabling floaters. So you got to make sure that what we're doing are the terminology is important. You can also look at contrast sensitivity function, quantitative ultrasound, or the visual function questionnaire. We don't typically use this, but we probably should. But a functional questionnaire is quite important for these patients. A multifocal lens really makes it difficult since you have different areas of near and far focus with these different types of refractive IOLs, and makes floaters even more prominent, as you can see here. So what all these do is they decrease the contrast sensitivity. So therapeutic options really are observation. Not sure about psychological counseling. Vitreous, which you don't really have, holistic treatments, really are going to be observation, YAG vitreolysis, or vitrectomy. And there's lots of people who do this sort of YAG for floaters. I certainly have not done it because we think vitrectomy is a really good option along with observation. In this procedure, you're kind of moving the problem from one area of the eye to the other area. So YAG vitreolysis, there's a randomized clinical trial in 2017, but this was for symptomatic Weiss ring, not floaters only, but just for symptomatic Weiss ring. And they did this study, and they looked at these different questionnaires, BCVA and fundus. And what they really found was the subjective and objective grading of resolution at 6 months with a qualitative scale. At 6 months, YAG was superior to sham on NEI responses, but there's no difference in visual acuity. So there's a moderate improvement. The problem is that small sample size, limited follow-up, no comparison vitrectomy. And again, this was only for Weiss rings. A lot of these patients will have anterior PVD and posterior PVD. So the anterior PVD is the anterior vitreous that causes a problem that this will do nothing for. Also, there is no contrast sensitivity function assessment for these patients. This was another study in 2019 of 132 eyes, and these are the different outcome measures. And in interest of time, I'm not going to go through all of these, but basically showed that there's a limited benefit of YAG for these patients. Certainly, I think that it's if that's all you have and you want to attempt this, I don't think there's any danger in doing this, but you have to remember that it is not always as successful as we think for moving a Weiss ring back and forth. This was another study from 2019 of unlimited vitrectomy. And again, when I do a vitrectomy for these patients, I think it's important to remove the hyaloid, make sure you have a PVD, induce a PVD. Typically, they should have a PVD if you've picked the right patients, and then do vitrectomy for them. And these are the outcome measures in this study with contrast sensitivity. They also did a cost utility analysis as well. And this was looking at the cost utility analysis. And this is a subgroup analysis. And look at the cost effectiveness for this procedure. So there was a significant improvement in all outcome measures. It was cost effective, vitrectomy. There was adverse events, cataract formation, retinal detachment, again, small sample size. And my rule for these patients is they must be pseudophakic if I'm going to attempt this, because only then can you make sure that you remove all of the vitreous in these patients. And again, there's no studies that have really looked at one versus the other. This was looking at a flow sheet that shows the Cochrane database for vitreolysis versus vitrectomy. So what about topical anesthesia? This was a study in 2018 from China, looking at 27 gauge vitrectomy for floaters, and they looked at analog pain scales. Typically, when I do surgery for this, I do them very topically, and this was a pain scale they used. The problem is that in these patients, that this was unclear the extent of vitrectomy performed, and there's no stratification by PVD in these eyes. So we want to look at our experience with topical anesthesia for vitrectomy for certain diagnoses such as floaters. And we published this back in 2018. This was a prospective study. Patients were selected primarily if they could cooperate in the clinic, and lack of significant squeezing with installation of drops. For anesthetic approach, we use proparacaine and also use some lidocaine gel at the beginning of surgery, which was washed off. If needed, rescue was available, but this was really not needed. And these are the patients that we operated on, 37 eyes with different diagnoses: vitreous hemorrhage, VMT, submacular hemorrhage, vitreous opacity, and endophthalmitis. We excluded conditions such as retinal detachment, cases that required peeling or extensive endolaser or prolonged surgical time. So this kind of just shows you day one, the presentation. You can't even see which eye had surgery. And the characteristics in our group were 72 years of age, who was the mean age. We did have our fellows participate in surgery, greater than 90% of the cases. And the data we collected was the most painful steps, amount of liquid, amount of IV anesthetic that was used, and the perceived adequacy of anesthesia. And this was a pain scale we used, and we collected this data. And this basically showed you the amount of pain at each time. So trocars, endolaser, scleral depression, and conjunctival closing. So the mean pain score was 0.7, quite low. 3 patients presented with a greater pain. They all had corneal epithelial defect, and this was due to a pH problem with a corneal lubricant. No defects otherwise were encountered when the change was made, and the mean post-operative week 1 pain score was 0 out of 10. No predictable risk factors for pain scores of 3 or higher. It really depends on cognitive experience, maybe their emotional state, maybe it's cultural background, but it was not unusual for most, or if not all, these patients to feel almost minimal to no pain. We also looked at the supplemental IV anesthesia that was given in topical cases, was retrobulbar, and you can see that we looked at our previous historic data and there was minimal change. So you can look at this, that during vitrectomy, we actually used very little in terms for more compared to retrobulbar cases. So these were topical cases, but not topical with IV sedation. So just be very clear of that. And this was another case, 71-year-old with floaters, follow-up 3, 4, 6 months, was offered vitrectomy. And here's kind of what it showed pre, and here's the post-op, shows the video quite nicely showing complete resolution for their symptoms. So yes, it does have risks, but all of life has risks. You know, these patients have real visual problems. Some patients hate these changes, multifocal eyes with floaters, and topical vitrectomy can be a great option for these patients. So I think it is important to consider surgery if they've tried observation. Do they have a multifocal lens, and do they have a convincing story? If the patient's fakey because there's other pathology or multiple procedures, I typically tend to not do them in these patients. So hopefully more and more outcome measures will be noted with further clinical trials in terms of contrast sensitivity, VFQ results, and quantitative ultrasound. So one of the other things we want to talk about is wide angle photographs. A lot of us probably get these, and you can see here's a wide angle asymptomatic retinal tear patient. Here's another one, another one. So, you know, what is the sensitivity and specificity of these wide angle photographs? So in Retina 2007, 60 patients with peripheral pathology, they were scleral depressed. Optos images was taken in 4 quadrants. The sensitivity of optos was 74% for lesions, 76% for lesions requiring treatment, and 45% for lesions anterior to the equator. BGO, 219 patients presenting with floaters, optos taken, 100% for detachments. If you look for 33% for holes and tears, 67% for the examining physician, typically a resident, 97% for retina specialists, 30% for other significant pathology. So really that optos is good, but certainly a clinical examination, especially with depression, detected more tears. So certainly use imaging, but certainly use your clinical examination along with imaging when you see these patients. And if you do find a tear, what do you do with these patients, right? Do we treat, not treat? Let me go back. This was a very old paper looking at an evidence-based analysis for prophylactic treatment for asymptomatic tears. And most asymptomatic tears really don't go on to have detachments unless they have a flap or traction associated with them. So the question is, do we always treat asymptomatic tears? Typically not. We always do treat symptomatic flap tears. We treat asymptomatic dialysis. Sometimes we'll treat asymptomatic flap tears if they're going to undergo cataract surgery, but we typically don't treat asymptomatic tears or even lattice in the fellow eye if the patient's even had a detachment, except if they have a giant retinal tear. And certainly, if the patient wants to have treatment for lattice in the other eye, I don't think it's it's nothing wrong. But there are some patients who sometimes don't want to have treatment in the other eye, and others who do. But certainly, if they have a flap tear, we certainly treat those patients. Here's a patient who came with multiple flap tears: 1, 2, 3, 4, 5, and along with a vitreous hemorrhage. So certainly those can be treated. Here's the treatment with laser therapy here, and here's cryo. I typically tend to prefer laser if I can get over cryo. In general, that's my preference. One thing that's really nice about tears and detachment is to do infrared imaging. Infrared reflectivity gives you beautiful photographs of tears and detachment. We published back on this in 2016. There's rapid acquisition, works well with small pupils. And here is, I'm not sure why it's going faster, but here is retinoschisis, easy to see compared to retinal detachments. You can also do OCTA. Here's pattern 1 on retinoschisis. There's different patterns. There's schisis detachment, and OCT will give you these different findings of different patterns. And this has been clearly published in the literature. So one of the key is I don't really have wide angle OCT at all offices, but we do have infrared imaging, which tells us the difference between a schisis and a retinal detachment. So ultra wide autofluorescence, I don't typically use that for this because I use infrared imaging, but that's another way to differentiate retinal detachment and retinal schisis. And this has again been published in the literature. So we talked about cryo versus laser for retinal breaks. The question is, are there more epiretinal membranes in one mode versus the other? And we published data that I was sort of amazed that it didn't turn out to be true in terms for, I'll give you the result, that whether we treat them with cryo or laser. So we looked at this study of looking at epiretinal membrane formation over a 10-year period and looking at these different diagnoses of macular pucker to time to development, time between treatment and ERM development and surgical intervention for ERM progression. We almost had about 2,200 eyes who underwent treatment for retinal breaks, with majority treated with laser and the rest with cryo. And overall, about 3% developed an ERM. The average time to develop ERM was about less than a year for both groups, for cryo and laser. So ERMs progress requiring surgery, 2 in the cryo and 5 in the laser groups, are really not a huge amount of progression either. But in the treatment of retinal breaks, there was really no statistical difference in the incidence of timing, severity of ERM from between these 2 modalities. Okay. So that was a paper that was published. It was well received and kind of showed you that 2 different things, which I was surprised did not make a difference. So let's talk a little bit about retinal detachments. The incidence, obviously, in the US is about 36,000 annually. The risk factors include cataract surgery, myopia, lattice, and trauma, all known to us. Patient status post-cataract surgery, it's 3% of the general population, but 40% of patients with retinal detachment, and most of them occur in the first postoperative year. Also, pseudophakic retinal detachments are more advanced, macula off, and higher incidence of PVR. The cumulative probability within 3 years after extracapsular cataract surgery is about 0.81. The risk factors, again, are myopia, 5 to 6 times the risk of retinal detachment. It's directly related to myopia. 1 millimeter myopia increase gives you a 1.3 times incidence of a retinal detachment. Risk factors, we already talked about this, are lattice degeneration, thinning, and firm adhesions. So symptomatic breaks, we treat. Asymptomatic, I typically do not treat unless it's a flap tear. So the options are really pneumatic retinopexy, scleral buckle, vitrectomy, or combined buckle vitrectomy. And we'll look at these preoperative factors and obviously our own experience in training and how we treat these patients. So pneumatic retinopexy is uncomplicated retinal detachments. You have one single break above the horizontal and patients are able to position. So typically the procedure is done with retinopexy, either cryo or laser, typically cryo, and then a gas injection of either C3F8 or SF6. The highest single operation success rate is in phakic eyes, 1 quadrant detachment, 1 break in the upper 8 hours. We avoid eyes with a high risk of redetachment, obviously. These are the different things that we use: tires, bands, and sponges. And this just kind of shows you from a retinal detachment chapter in Ryan or Nianov that we wrote, shows the cryo being done. Here's the drainage being made. And here I like to use this Amira with a cut down to cauterize the choroid so I don't get bleeding at the time of surgery. And let's see here. This just shows a 41 band. I usually use a 277 tire such as this, or a 41 band for these patients. And again, you've got to make sure you have a nice conj closure in these patients. This is a retinal detachment that you can see, and here it is fixed with the buckle. I still like doing buckles. They work well for atrophic holes in lattice, inferior dialysis, extensive lattice, and especially young patients. So it is a good procedure. The advantages of vitrectomy, certainly we work from the inside. We identify and treat all retinal breaks, release traction. It's certainly a more expensive procedure, but it can work well for many patients. And I think more and more people are being more comfortable with this. So I think you should do the procedure that works best in your hands. But I certainly think it's good to have as many different tools in your armamentarium. And here's a patient who has a retinal tear with a retinal detachment, and you can see post-buccal vitrectomy. Here's the buckle and then laser treatment. Here's just some intraoperative photographs of patients who are having a depressed examination, which I think is really important when we do a vitrectomy in these patients. Now, one thing I do like to is this is post-op day 1. You can actually get a photograph. So here's a patient who had a retinal detachment post-op day 1. You can see through the air bubble, and now typically I use air. I don't use gas for superior detachments. You can see the laser treatments. Nice to show the patient, but you can actually get a beautiful photograph. This is for the wide-angle imaging system, just post-op day 1. So I also want to talk about the PRO trial. This was looking at which procedure works best for these patients. This was a series of papers that Ed Ryan spearheaded, and we were participants in this. I'm sorry. This shows the groups in Minneapolis, St. Louis, Detroit, Boston, and Philadelphia. So the Minneapolis group, our group, Beaumont, Mass Eye Near, and Wills Eye Hospital. So sort of 5 really busy, large retina practices that contributed to this. And these are the lead authors at each institution. So we looked at all primary retinal detachment cases from 2015. So all OR, usual exclusion factors. We looked at, these are our numbers, males, age, follow-up, total number of phakic patients before exclusion. And then we looked at who was eligible. So scleral buckle, 91%, vitrectomy, 84%, vitrectomy buckle, 90%. Okay. Single operation success rate. And we found that vitrectomy was inferior to vit buckle or scleral buckle for single operation success rate for phakic retinal detachments. Again, phakia. So if you just did a vitrectomy alone, it was inferior to both of these procedures. Macula off, and you can look at the mean final vision for scleral buckle vitrectomy and vit buckle. And this again looks at the final vision of 2200 or worse. What's important to note is in the vitrectomy group, there were more patients with final acuity vision 2200 or worse. And the principal reason was really unknown of why this occurred, but it might have been maybe due to an optic nerve or neuropathy, which I think is an important cause of vision loss in vitrectomized eyes. So I think that it's important that this for phakic eyes, scleral buckle still remains a really good procedure to learn and to do, and certainly had not only as good of a success, but a better success than primary vitrectomy. So let me sort of go through, this was for pseudophakic eyes, and for pseudophakic eyes, anatomic outcomes were superior in the vitrectomy buckle and vitrectomy buckle group versus a buckle. So again, kind of complemented what we know. So if you have a pseudophakic eyes, I certainly think you can do a buckle if that's all you have, but vitrectomy or vitrectomy buckle works well in these patients. And relying on vitrectomy alone for inferior detachments is where vitrectomy buckle was superior to vitrectomy alone. So it is important that maybe for pathology that is inferior, that it's important to use maybe a vit buckle. And also if you have multiple breaks and hemorrhages and so on and so forth. Now, what about timing of retinal detachment? We're often asked about, gee, you know, when should we do this? You know, here's a patient, let me go back, who has a macular threatening detachment. Certainly, I think timing is always difficult with availability of OR resources, and I think each person's situation. So we have to kind of keep that in mind. And this kind of shows different types of detachments. So timing is maybe much more important for, let's say, a giant retinal tear versus an inferior detachment noted here. So we look at the prognostic factors, acuity, macula on or off status, height of detachment, patient age. And preoperative visual acuity is really the strongest indicator of postoperative visual outcomes, right, for retinal detachments. Here's a detachment with a break, and another detachment, another detachment, another detachment. So all these detachments, here's an inferior detachment. So for this, you can see demarcation line. The urgency for this detachment compared to this is going to be much lower. Here's a giant retinal tear that is kind of on this way of flipping over in this patient and extending. So that one you want to do sooner rather than later. Here's another patient who has a thin area of fluid, but you can see this has been there for a while. Whenever you see this on the ultrasound, this thickening, that means that detachment has been there maybe for weeks, okay, and not acute. Here's another detachment, shows this sort of what appears to be this dark elevation. This fluid's been there for a long time, and you can see that. So this patient, even though the macula is splitting, you can see this thickness right here. And this has been there for about 3 months. So no urgency here. You can see this patient right here. This is the chronic fluid. This is the more of the acute component. And you can see this on the infrared photograph, this stippling appearance. And here's the retinal hole that you can see quite nicely on infrared. Another chronic detachment. So when you look at these detachments, they really look like they've been there for a while. Here's the break that caused the detachment, and here's the guttering of fluid. So important to know chronic. So clinical reality really for macula off status, really no difference in the first week. For macula on, I think several days can be acceptable depending on, you know, the type of detachment that they have. And again, in the interest of time, I'm kind of skip through this, but basically showed that even for macula on retinal detachments, you can certainly wait for a few days if you cannot get in the operating room. That these were patients, 200 eyes, they're repaired within 3 days, and only one progressed to a macula off status 4 days after presentation. And this is typically how it advances about 1.82 disc diameters per day. But again, make sure that it's the state of the vitreous will depend on how much of the extension. So if you're unsure, certainly consider OCT and really look at the patients to look if it's acute or chronic, because you can do that quite nicely on examination and OCT. And one of the things that patients get even after you repair them is this issue of aniseikonia, image differences. So remember that compression of photoreceptors gives you macropsias, seeing images bigger, and stretching gives you micropsias. So sometimes patients complain, not that their visual acuity is not good, but I think they're complaining about image size differences. And I think that's important to let them know that that is a possibility in retinal detachments. This just kind of shows you a misalignment of photoreceptors. You have less number of photoreceptors here and more here. So there are fewer signals in the image on the left versus the right. So the photoreceptor density on this is normal, and this is a retinal reattachment. So these patients, when they have less of this, they're going to get micropsias. Okay, so this is normal and this is abnormal. So that's a very important point with macropsias and micropsias. So macula off patients are more likely to have micropsias, and macula on more likely to have macropsias. Okay. When we also look at retinal considerations, people always ask us for LASIK or clear lens extraction. Do we treat these patients for retinal tears? Okay, and I certainly don't typically pre-treat. I certainly do examination, but I don't really pre-treat them. Again, people have thought the mechanism of injury is a suction that is applied during LASIK. Maybe there's an excimer shock wave, but I certainly think that nobody really knows why that occurs. I typically have not really seen too many patients post-LASIK. Right after LASIK, they get it afterwards, maybe a year or two, but again, they're high myops. So it's really not the procedure itself, but just the vitreous issue that caused it. So the RD after LASIK, it's again more often involving the macula. PVR is more common, and the incidence is about 0.6 to 0.36%. And if you look at the timings, this just kind of shows you that most typically occur in the first 2 years after LASIK surgery. This just kind of shows you a flap complication. You want to be aware of this when you're operating on a patient with LASIK. I just did surgery 2 days ago, and somebody had LASIK, so you got to make sure you don't scrape the endothelium. If you need to, make sure that you're doing it in a way that's you're not taking the hinge and you know where the hinge is. Okay. So usually LASIK is a safe procedure, but again, myopia is not always safe. But again, if you're not sure, certainly look for retinal examination for peripheral pathology and macular causes for vision loss in patients with LASIK. Clear lens extraction, certainly more and more refractive surgeons are doing that, and that doubles the risk of retinal detachment compared to myopia without surgery. Prophylactic treatments, I think we already talked about that. Phakic IOLs, similar issues. These are IOLs placed in front of the eye's natural lens. Sometimes visualization is hard in this patients. I've luckily only had to do surgery twice in patients like this, and sometimes it is difficult to see. So these are these multifocal IOLs that patients get put in, premium IOLs. And all I can tell you is that these can be problematic to operate because of the material, and you have to look through these different rings that these patients have. So the Resume, Restore, Technis, crystallines, silicone is a material. In these, it's acrylic, so it's a little bit easier, but that will cause an issue of condensation during the surgery and also centration. So these lenses, if they're not centered, it becomes problematic. Okay, and condensation is an issue. So really, you can use viscoelastic for this, or what I typically do is I put the infusion line through an ice bath to condense the water in the line rather than the eye. That makes it easier for condensation. Also, if you have a silicone lens, you've got to be careful with silicone oil droplets because they will bind to the material of the lens, and they're also difficult to remove as well. And visualization can become harder because you will get this image jump in these patients. And this is a unique to crystal lens, the Z syndrome, where you have flexion at one hinge and you get asymmetric torque or forces, and then you get this lens that is Z-centered. So again, got to be careful. The ideal IOL from a retina perspective is certainly going to be a nice optic, that it's silicone, and then you don't have this phimosis of the anterior capsule that becomes problematic. So I think we've talked a lot in the last 43 minutes. So I think PVD and retinal tears are continuing to increase in the world with increased incidence of myopia. Wide angle imaging with direct and depressed retinal examination, I think in high-risk patients is important, along with imaging. I think retinal detachment repair continues to evolve. There's new lens technology that adds to the complexity of surgical repair. And I do think that patient expectations have to be managed in the pre-operative and post-operative period. So I think that is important for that. And this is a beautiful picture that I took many years ago with my iPhone of sunrise towards a place called Canyonlands. And one of the things I like to enjoy is to hike and look at what nature has, because to me, that's one of the beauties in life, that when we restore vision to people, I want them to see beautiful images like this that I've been privileged to see in my lifetime. And our patients, unfortunately, with vision problems cannot see some of these images. So our goal is to have them see beautiful images that nature has made for them. So that's about for my talk. I hope you've enjoyed it. I have some question and answers that we have. In the interest of time, I can go through some of these. There's a question of oculoplasmin for vitreous floaters. We typically don't use oculoplasmin. It's not even available because of the issues. Another question said, it is challenging in patients who have a vitreous hemorrhage about how to look at the retina. Again, try to sit the patient up, ultrasound, wait, and if you're not sure, vitrectomy. Another question was looking at floaters in young patients between 20, how can we reduce them? We really can't reduce them. And they really have vitreous syneresis. They really don't have floaters per se. So I think that it's important in younger patients that we make a clear distinction. Retinal detachments, what I mentioned was that if you have an inferior retinal detachment and you cannot get into the operating room, then very few progress within 3 days. So it certainly is important that you do them in a timely fashion, but if you can't, then the risk of progression is going to be not as high as you think. How often should we follow patients with symptomatic PVD, look for tears? We're going to have a paper coming out on this, but I typically follow them in a month. If they have a vitreous hemorrhage associated with them, that issue is going to be very different. You need to see that patient quite frequently, every couple of weeks, to make sure you're not missing a tear. So I think that's really, really important. The cause of floaters in young patients is really not a PVD. It's more of an anterior vitreous syneresis, and that's what happens in these younger patients.